Hello everyone, my name is Yu Jiaju. I'm from Department of Urology, Shandong Provincial Hospital. We would like to share a multidisciplinary treatment case report of ductal adenocarcinoma of the prostate. The abbreviation is DAP. DAP is a rare pathological subtype that is challenging to diagnosis or treatment. This patient was initially diagnosed as DAP in our hospital, while diagnosed as seminal vesicle adenocarcinoma in another hospital. After 4 times of diagnosis and treatment by MDT team, we finally confirmed our diagnosis and achieved good results. The patient was a 61-year-old man admitted to our hospital in May 2020 due to initial gross hematuria accompanied by low urinary tract symptoms. Ureteroscopy revealed a cauliflower-like tumor on the posterior urethra. Combined with the hematuria, we initially considered whether it was a urethral tumor. However, the biopsy pathology ruled out the urethral tumor. Considering positive PSA staining, it was suspected to be DAP and involving urethra. The serum PSA was within the normal range, but digital rectal examination can touch an enlarged and hard prostate, and a poor range of motion between the prostate and the rectum. MRI showed a typical local advanced prostate cancer involving the right seminal vesicle gland and locally protruding to the rectum. No obvious abnormalities were observed in the whole body Boeing scan. Considering the patient's young age and a strong desire for treatment, we also hope to provide him with a chance of cure. Therefore, we organized a MDT team that included doctors, urology, radiology, pathology, and oncology experts to assist in diagnosis and treatment. Based on the available evidence, MDT experts support the diagnosis of DAP. The clinical stage can be classified as T3B to T4 high-risk group. However, considering the unclear boundary between the prostate and the rectum, the risk of intraoperative damage to surrounding organs and positive margin, 4 to 6 cycles of neoadjuvant chemotherapy with docetaxel combined with cisplatin and adjuvant deprivation therapy (ADT) treatment were recommended. 2 months after admission, the patient began to receive neoadjuvant chemotherapy. After 4 cycles of chemotherapy, MRI revealed that the scope of the focus was significantly reduced. The boundary between the prostate and the surrounding tissue is also cleaner than before. At this time, the serum PSA level decreased significantly, and the testosterone also reached the castration level. DRE revealed that the prostate volume, the texture, and the range of motion was significantly improved. Based on the above evidence, the second MDT consultation concluded that the patient had achieved partial remission and it was the time for surgery. 3 months after neoadjuvant surgery, the patient underwent a laparoscopic radical prostatectomy and bilateral pelvic lymph node dissection, and the surgery was successful. Postoperative pathology was still considered as DEP, involving the right seminal vesicle gland and locally presenting mucinous adenocarcinoma. No cancer was detected at the resection margin and the lymph node except for the suspicious resection margin at the blood neck. At this point, we were faced with the problem of follow-up treatment. So, a third MDT consultation was organized, considering the consistency of postoperative pathology and biopsy, the effectiveness of the preoperative regimen, and the suspected positive margin. The experts recommend continued chemotherapy according to DP regimen for 2 cycles. Local radiotherapy can be performed after urinary continence has recovered. Unfortunately, the patient refused to continue chemotherapy or radiotherapy and chose only a periodic review. 6 months after operation, the serum PSA level remained at an undetectable level, and no local recurrence was found on MRI. However, 10 months postoperatively, the serum PSA increased to 0.05 nanogram per milliliter. In addition, CT images revealed multiple newly occurring small nodules in bilateral in the lungs, approximately 19 of which were considered as metastases. Then he went to another hospital for consultation, and the PET-CT also suggested multiple metastases in the bilateral lungs. The immunohistochemical staining of PSA was still negative, which was consistent with all hospitals. And no pathogenic gene changes were detected, and no specific target drugs were available. However, the other hospital eventually made an unexpected diagnosis of seminal vesicle adenocarcinoma, which is even rare. We recommended 4-FOX chemotherapy regimen, which is commonly used to treat intestinal adenocarcinoma. We were surprised when the patient returned to our hospital. Was our previous diagnosis incorrect? We organized a 4th MDT meeting to find the answer. The diagnosis criteria provided by the other hospital were mainly based on the points shown in the figure. They believed that, except for the absence of cancer in surrounding organs such as the prostate in second point, it is generally consistent with seminal vesicle adenocarcinoma. But we did not think so, because the first and often the most important point was that the main body or center of the tumor was located in the seminal vesicle gland, which was obviously inconsistent with this case. After reviewing the earliest images, MRI images clearly indicated that the main body of the tumor was located in the prostate, mainly in the central glandular area, and was only partially involved in the right seminal vesicle gland. We then made an immunohistochemical comparison. The red section shows the negative expression of PSA and PSAP. However, we also found that there were exceptions in previous reports. Pathologists believe that it may be caused by poor differentiation of the tumor or loss of antigen after chemotherapy. Therefore, it does not completely rule out prostate origin. In addition, blue labeled markers such as CA125, MUC6, PX8 were negative and cannot effectively support seminal vesicle adenocarcinoma or similar sources. Additionally, the characteristics of urethral cauliflower-like mass, hematuria, normal PSA, lung metastasis in this patient were consistent with those of DAP. Therefore, combined with the openness of MDT, we finally insisted the diagnosis of DAP. Due to the occurrence of lung metastasis, our oncologist recommended that he should be treated with DP regimen as soon as possible. At present, the patient has accepted our diagnosis and recommendations for active treatment. In conclusion, from this case, we can see that MDT played an important role in the diagnosis and treatment of this case. Preoperative neoadjuvant chemotherapy is effective for DAP. Surgery is still an important method for the treatment of DAP. DAP has a high degree of malignancy and poor prognosis, so postoperative adjuvant treatment is necessary. That's all. Thanks.